I think it's really important for people to understand that there is a whole population of patients living with metastatic disease. It's just like having treatment for diabetes or a thyroid problem. Our goal in the Bone Metastasis Program is to keep our patients going every day, to live on with their family and have a good quality of life.
Metastasis is really just a word for a cancer that spread from some place where it began to some other part of the body. A cancer that spreads from where it started to bone. Oftentimes there are unique issues that come along with that. When I'm evaluating a patient as a medical oncologist, the bone aspect of the care is not my primary expertise. And so the best care for the patient is when I can be team-oriented and I can easily reach out for input from someone who thinks about the bone aspect of the care all day long.
We want to make it easy for any physician or any advanced practitioner who has a patient in front of them and has the question of, do I continue with my chemotherapy treatment, my radiation treatment, or does this individual need surgery? And that's the three major questions that we answer quickly on a timely basis.
Cancer is very difficult. We don't need to make it more difficult for the patients. We just have to, every treatment, every visit, try to make it easy and especially do it if it's necessary. So show an X-ray, so show a CT scan, an MRI. My patient has this image and doesn't have any symptoms. Does this patient need to see you? No. Or I have a patient that cannot walk. I have this large lesion. I'm worried about what is happening. The patient is getting this chemotherapy. And with that information, for example, I can say, okay, looking at the images, your patient is going to need surgery. Why? We don't increase the pain medication. Protect the weight bearing of your patient, give him some crutches, stop the chemotherapy now, and I'm going to see your patient next week with plans of admitting the patient, do surgery.
Our bone metastasis program is unique in that we stress to our patients that we are not taking over their primary care. We are just a consult to band-aid that problem that happens. Many patients living with metastatic disease have a problem and they're surgically fixed, if you want to put it in easy terms, and then we return them back to their primary physician, their primary medical oncologist.
When I think of collaborative care, one example that immediately comes to mind is a patient that I was soon to meet who had bladder cancer. And I was reviewing her chart and her imaging, and I was looking at a spot of cancer, a metastasis, a spot of cancer that she had in her pelvis. And so when I looked at that image, I thought, I wonder if that area is at high risk for fracture. What I did right away was reach out to Santiago for his thoughts. I told him about the scenario and what I was worried about. And he reviewed the images and the scenario himself and said, I think I should meet her right away because we need to figure out whether this is at risk for fracture and whether she needs surgery. And so reaching out for that kind of input in real time is just crucial for the care of patients who have bone involvement by their cancer.
There are things that we can use like photodynamic nails, carbon fiber nails, navigation, tools that they're not available in every hospital. So for example, we have now these implants that we can put in the pelvis that are radiolucent, that compared to previous surgeries that were more extensive, they can be done with very small incisions and they provide good pain relief. Taking into consideration that the patient has to recover quickly to get chemotherapy, I do a very cutting-edge surgery that is percutaneous, 2 days stay at the hospital, and allows to get the patients, for example, a faster recovery from surgery to getting to chemotherapy. We use, for example, carbon fiber rods that are very good to plan radiation. So when you put a metal implant and you plan your radiation treatments, when the medical oncologist gets the CT scan, gets a lot of scattering and it's very difficult to plan the radiation. We can put implants that are made of carbon fiber that don't make that scattering effect. And that helps the radiologist, the radiation oncologist to plan the radiation and the radiologist to assess the bone. So that collaboration is what the complex care of this type of patients require.
The program is new, but the expertise and the research that is currently going on, whether it's the effective radiation on bone or whether it's a new type of technology in surgery to stabilize a bone that's been affected by a bone met, that's ongoing and will continue. We just want one large network to give the support that medical oncologists and radiation oncologists, even primary care physicians, need to treat the complexity of a patient with cancer.
It's that kind of an approach that produces the best outcomes, the best care, the best holistic care for the patient.